This is the second lecture for the integumentary system. In this lecture, we'll discuss some pathological findings of the skin and some of the ways that abnormalities of the skin can lead to some clinical diagnosis. This may be a little more interesting because it has more of a clinical appeal. First topic I want to talk about is how skin color can be used in diagnosis of certain medical conditions. The first abnormal skin color is cyanosis. Cyanosis is a blue discoloration of the skin. It's caused by the lack of oxygen in the blood. Cyanosis is associated with cold temperatures, with heart failure, with lung disease, with smothering. It can indicate many different things such as low oxygenation, airway obstruction, drowning, emphysema, respiratory arrest, or frostbite. Cyanosis is a picture of cyanosis of the fingertips here. This next picture is an example of erythema. Erythema is redness of the skin. It's caused by congestion of the capillaries beneath the skin, so there's more blood flow beneath the skin and more blood released beneath the skin, giving it a red appearance. Remember, the hemoglobin in the blood gives a red appearance. Erythema is seen in cases of fever, with sunburn, hypertension, inflammation, allergy, anger, or embarrassment. So a lot of things can cause erythema. This condition, notice that the skin, the hand is lighter in appearance or white colored. This condition is called pallor. Basically, this pale skin or blanching of the skin. You see this in the cases of anemia, low blood pressure, cold temperatures, and emotional stress. Notice here, this is not so much the skin, but it's the sclera of the eye, the whites of the eye become yellow, and the skin has an orange coloration. This is called jaundice. Jaundice is yellowing of the skin and of the sclera. Bilirubin is a product of hemoglobin breakdown. Hemoglobin is in the blood. When red blood cells get old and they die, they disintegrate, they release their hemoglobin. The liver and the spleen convert the hemoglobin to bilirubin, which is then excreted as bile by the liver. If the liver function is impaired, the bilirubin cannot be excreted and therefore accumulates in the skin and the sclera. So when bilirubin is present, it causes this yellowing of the skin called jaundice. So jaundice is found in liver disorders such as cirrhosis of the liver, hepatitis, liver cancer. It's also seen in premature infants because they don't have a functioning liver to rid the body of the bilirubin. Here's a bruise, and notice the different skin coloration of a bruise or a black eye, which is basically a bruise around the eye, periorbital bruise. A bruise is basically clotted blood beneath the skin. It goes through these different stages. If the blood is beneath the skin, initially it has a red appearance because the blood is exposed to oxygen. And as that blood breaks down, just like in the case of jaundice, the breakdown of bilirubin causes a yellow discoloration. So you see the bruise starts to become more yellow and brown in coloration, and the redness fades. It eventually becomes brown, and then redness just fades. Eventually it returns to a normal coloration. So depending on the length of time from the origin of the bruise to the recovery time, the bruise can be a different color from red to yellow to normal skin color. This is not skin coloration, but this is a feature of the nails that's characteristic. Notice that the nails have a rounded shape and are swollen appearance on the end. This condition is called clubbing. And this is seen with pulmonary disease, cases like heart disease, emphysema, COPD, lung disorders, chronic lung disorders, cystic fibrosis, things like that would cause this condition called clubbing. We'll look at different components of the hair. Some we've already mentioned before. The hair shaft is the part of the hair above the skin. The hair root is the part of the hair below the skin. The hair follicle is this bulb area surrounding the hair root. The hair follicle grows the hair by packing old cells together, compressing its keratinocytes together to form the hair. That's done by the hair follicle. Hair follicle is part of the skin that grows hair by packing old cells together. Hair root is a part of the hair within the dermis, or the part of the hair below the skin. Diagram of hair matrix. Basically, these cells here. These are the actual cells that grow and become hair cells. These cells actively divide and grow, and just like the skin, how these cells migrate towards the apical side, these cells migrate, and the migration is how these cells upward is what causes hair to grow. Here's the erector pili muscle. Again, it's that smooth muscle, involuntary muscle that causes the hair to stand on end. This is responsible for goosebumps in humans, and causes it's what lets a cat or a dog have the hair stand on the back of the neck when they get around another animal they want to have a conflict with. Now we look at sweat glands. Two main types of sweat glands are eccrine sweat glands and apocrine sweat glands. And all the skin surfaces except for the nipples and parts of the external genitalia contain sweat glands. The eccrine sweat glands is the most numerous type. It's abundant on the palms, soles, and forehead. These are ducts connected to pores. So again, these are what kind of glands? They're exocrine glands. The function of these exocrine glands, or eccrine sweat glands, is for thermal regulation. They're responsible for cooling the body off. The sweat basically deposits water on the surface of the skin, and then when air flows over the skin, it has a cooling effect, which cools the body, and therefore it results in the homeostasis of body temperature by cooling the skin and cooling the body. Apocrine sweat glands are different type of sweat glands. These are confined to the axillary region, which is the armpit region, and the anal genital region, the areas around the anus and the genitals. This is a milky or yellow sweat that contains fatty substances and proteins. Bacteria break down the sweat and it leads to body odor. These are larger than eccrine sweat glands, and the ducts of these glands empty into hair follicles. There's a few modified apocrine glands of note. The ceruminous glands, which are in the lining of the external ear canal. These secrete earwax, cerumen, earwax. Also, mammary glands are modified apocrine glands that secrete milk. Sebaceous glands are oil glands. You see these this is around the hair follicle here. These sebaceous oil glands. What's unique about these glands is they're around the hair follicle, so they secrete their oily substance in and around the hair. That's what gives the hair an oily appearance after it's not been washed for a period of time. These secrete by the holocrine secretion. That's when they rupture. The sweat glands rupture and release their secretions that way. Well, what are the functions of skin? Skin has certain functions, and we'll talk about those functions next. Protection is one of the major functions of skin. The skin is a barrier. It's a barrier between the inside of the body and the external world. It's a chemical barrier, it's a physical barrier, it's a biological barrier. Chemical barrier, because it has chemicals like in the sweat, there's antimicrobial proteins that help fight against bacteria, help kill bacteria. The pH of the skin retards bacterial multiplication. The melanin provides a chemical barrier against ultraviolet radiation damage. So the skin has several mechanisms for chemical barriers to protect the body. There's a physical barrier, which is composed of the dead, flat, keratinized cells of the stratum corneum. Basically, they act like these sandbags that are stacked on each other to repel water, make it a watertight barrier. Very similar to the way the keratinocytes repel water by being very tightly packed. And biological barriers has to do with the fact that there's phagocytic cells. Those Langerhans cells or dendritic cells. They engulf foreign antigens and foreign pathogens, activate the immune system response, and help get rid of the infection. Epidermis these are found in the epidermis, as you remember when we studied the epidermal layers. And the dermis has macrophages that do the same type of thing. They eat and destroy antigens from invading pathogens. The cutaneous nerve receptors are part of the nervous system. These are found inside the skin. So the purpose of the skin is for sensory feedback. These exteroreceptor is basically a receptor that detects sensations from outside the body. So this would detect things like temperature and touch. So if you touch something that's cold or hot, these are transmitted through exteroreceptors. Pain can be detected from free nerve endings. So there are many nerve endings. Free nerve endings detect pain. These lamellar corpuscles or Pacinian corpuscles like this detect pressure. Skin has a function of synthesizing vitamin D. Vitamin D is needed to absorb calcium from the intestines. Skin can hold up to 5% of the body's total blood volume. So skin can be like a source for additional blood. If in the case of shock or if there's bleeding, organs can be the blood can be controlled to come from these organs and from these areas of the skin where maybe non-vital portions of the skin to deliver blood to more vital portions such as around the brain and the heart. And the skin is important for excretion. There's from sweat, there's salt and water loss, and skin can secrete waste such as ammonia, urea, and uric acid through the pores of the skin. So the skin has an excretion feature or function as well. We'll look at some skin pathology now. Let's look at skin cancer. This is something that I guarantee you that in your lifetime, and if you're working in healthcare, you'll sometime have somebody that asks you to look at this mole or look at this spot on the skin and want to know if it's skin cancer. So these are the three most common types of skin cancer. The risk factor for skin cancer is overexposure to ultraviolet radiation. Period. That's the number one risk factor for skin cancer. Any skin cancers is radiation, ultraviolet radiation, sun exposure. We'll look at three types of skin cancer. First is the basal cell carcinoma. This is the least malignant and most common of the three. This is the result of cells from the stratum basale, the basal layer of cells that proliferate and slowly invade the dermis and hypodermis. The good news about these cells is that 99% of the time they're cured by surgical excision. The key is getting them to see the dermatologist or the surgeon soon enough to have it removed. If it waits too late, then the cancer becomes deeper and it makes it harder to be cured. But early on, it's a 100% cure rate if they're excised early enough. The next type of skin cancer is squamous cell carcinoma. This involves the cells of the keratinocytes, skin cells of the stratum spinosum. And in this case, these cells start to multiply without regard to other conditions that would normally inhibit their multiplication, and results in a scaly reddened papule, which is basically just a raised area on the scalp, ears, or lips, basically any sun-exposed area. Again, like the basal cell carcinoma, it's a good prognosis if they're removed surgically early enough, and they also respond to radiation treatment. This is the second most common type of skin cancer, and this can metastasize. Metastasize means it spreads to other areas of the body. But by far the worst of the skin cancer is the melanoma. This is cancer of the melanocytes. This is the most dangerous cancer because it's highly metastatic and it's resistant to chemotherapy. It's treated by a wide surgical excision. That means that a large area of the skin is taken out. Try to capture all the skin cells that are to become cancerous. Here's some examples of melanoma. There's an ABCDE rule, and you could use this to help determine if the mole that your friend has is something that needs to be seen by a doctor, or if they could just wait. Certainly, the A stands for asymmetry. Notice that in both examples, they're asymmetrical. They're not circular. They're kind of asymmetrical. They're not a really defined pattern. It's certainly asymmetrical here. A symmetrical lesion would be something that's circular or round. The B stands for border irregularities or indentions. See, these have indentions here. They're not smooth borders. They're irregular borders. C stands for color. Sometimes they could have several colors inside: black, brown, tan, sometimes even red or blue. Notice how this one has different shades of darkness. There's brown, there's darker, black. D, diameter. If it's larger than the size of a pencil eraser, then it's more than likely some sort of carcinoma or melanoma. And the last parameter is E for evolution or evolving, changing with time. So if it looks like this today and then 6 months from now it looks larger, then that's not a static process. That's a process that's evolving and getting worse. So if somebody comes to me and says, "Is this something I need to go see a doctor for?" The best answer to give is when in doubt, go to the dermatologist and let them take a biopsy, and then that way you know for sure. It's better to err on the side of having a normal biopsy than to not having the biopsy and turn out to be melanoma. But hopefully with knowing these features, you'll be able to better predict whether something is cancerous or non-cancerous. Another pathological process that occurs on the skin is burns. Burns can be caused by direct heat, electricity, radiation, or certain chemicals. The immediate damage, or the immediate threat, is dehydration and a loss of electrolytes. This can result in shock and shutdown of the kidneys. So this is basically an immediate threat after burns. You need to watch out for dehydration and loss of electrolytes. And if you've heard anybody with burns, you might hear that they use a percentage of how much body percentage is burned. This is evaluated by the rule of nines. The body is broken into 11 sections. Each section has 9% of the body surface. This next diagram shows. So the face has 4.5% on the front of the face, 4.5% on the back of the head. That totals 9%. The anterior trunk is 18%, which is 2 times 9. The back of the trunk is 18%, which is 2 times 9. The anterior arm is 4.5%. The posterior arm is 4.5%. So the total arm is 9% of each arm. The leg is 9% of the anterior leg, 9% of the posterior leg. So we add all these up, and the perineum is 1%. So add all this up is 100%. So if somebody comes in, for example, and they're burned over their entire anterior surface of the left leg, for example, then you'd say they have 9% of the body burned, so it's 9% total body burns. If their whole leg was burnt, posterior and anterior, it'd be 18% burns. So you just add up the portions of the body that is burned, and that gives you the rough estimate of the percentage of skin that's burned. If they come in and the anterior arm is burned, that's 4.5% burns in the total body. That just gives you a rough estimate of body percentages of damage with burns. Burns can be classified by severity. There's first-degree burns, which have only damage only to the epidermis, and this presents with local redness, erythema, and pain. An example of a first-degree burn is sunburn. It's basically just redness. It just affects the epidermal layer. It's not deep. It's painful because, remember, the epidermis is innervated. But sunburn is a classic example of first-degree burn. Second-degree burns involves damage to the epidermal region and also the upper dermal region. With second-degree burns, you have blisters. That's a feature of second-degree burns. A third-degree burn is a full-thickness burn involving the epidermis and the dermis, and at times maybe even the hypodermis, depending on how deep the burn is. The skin color turns gray or white, red or black. There's no edema, and the area is not painful because the nerve ending has been destroyed. So the third-degree burns is not painful, but typically if you have a third-degree burn like you have here, the surrounding areas may be lesser intense. It may be a second or first-degree burns around the edges, and that would certainly be painful. So I don't want to indicate that third-degree burns are not painful, but it's the portion that's third degree is painless because the nerves have been destroyed. But the surrounding area would be painful because the nerves are intact in the surrounding areas. For this to heal up, a skin graft is usually needed. Here's an example of first degree and second degree burn in the same hand. This could be a scald injury, for example. You have first degree burn, just redness of the fingers. Second degree burn is noted by the presence of this blister here on the palm. Third degree burn is a full thickness burn involving the whole thickness of the skin, epidermis, dermis, and maybe the hypodermis. A burn is considered critical if 25% or more of the body has second degree burns, or if 10% or more of the body has third degree burns, or if there's burns of the hands or feet or face. And remember, the first danger with burns is fluid loss, dehydration, and electrolyte damage. Later on, after you've stabilized through the first stages, the thing to watch out for is infection, because with the skin being burned, that makes the skin very susceptible to infection by bacteria. That's why antibiotics are important. Temporary covering is important to try to restore that boundary to keep bacteria out. That concludes the integumentary system lectures.